Hello, welcome to part 2 of the Botox for Bunions video series. If you haven't already, watch part 1, which talks about the evidence for using Botox for bunions. In this video, you will see the actual procedure being done, the actual injection being done, which is ultrasound guided and EMG, electromuscular stimulated guided injection. Before we do that, let me introduce you to my patient. Well, my patient's foot anyway. This is my patient's foot. She has a mild, painful bunion. It is stopping her from wearing the footwear that she wants to wear, and she finds it quite uncomfortable when she does long walks and certain types of exercise. We are classifying her bunion using the Manchester scale for the classification of Hallux Valgus, which is bunions, which is a validated scale. As you can see from the scale, A is no deformity, B is a mild deformity, which is where I think our patient sits, C is a moderate deformity, and D is a severe deformity. If you have either B or C, either a mild or a moderate deformity, I feel that Botox for bunions can help you. If you have D, which is a severe deformity, then you need to go and see our surgical colleagues. We also did some x-rays of our patient, and we're going to carry on doing some x-rays of our patient during the course of the next 6 to 12 months. This first x-ray is the first metatarsal phalangeal joint angle. I'm trying to get the words out of my mouth. A normal first metatarsal phalangeal joint angle is 15 degrees or below. I'll put up a reference here. Our patient is about 12 degrees, which is within the norm, but it's moving up towards becoming classified as a bunion. The second x-ray is the intermetatarsal angle. Now the intermetatarsal angle, the normal is 9 degrees or below, and I'll put up a reference here. Our patient actually has a 20 degrees intermetatarsal angle, which would account for some of the deformity and pain she has. We've also done a Manchester Oxford foot questionnaire, which is a validated questionnaire, and I'll put up a reference here, which she has scored quite highly for, and we will do this questionnaire a few times to find out how it's affecting her function after the procedure itself and for the next 6 to 12 months. Now that I have introduced you to my patient's foot, let me go and get changed into my scrubs, and let me welcome my colleague, Mr. Mia, who is going to be helping me today with this procedure. I went through the evidence in detail in the first part of the video series in part 1. In this part, we are going to be doing the procedure, and then part 3, which is going to be made in about a couple of months' time, when we're going to go back over the x-rays of the patient, go over the patient questionnaires, and try and see what kind of effect it has had. We know from reading the previous papers that have been done, and from myself speaking to podiatrists in the States, which we have.
We corresponded with them.
And it is an effective treatment option. But to be able to provide a non-surgical solution for Hallux valgus, which is bunions, is an exciting prospect, because right now what most podiatrists do is either we give orthotics, we give exercises, we give some footwear advice rather, and then we say, oh, after that you can't have anything done, you got to have surgery done, and there are consequences, long-term consequences of having surgery. So to be able to use Botox in this manner to help a bunion is really exciting.
Well, let me put you in a crystal clear scenario. Bunion surgery is the last resort.
That's right.
And by the way, before anybody, I have done it. Previous life of mine, MIS, which I don't do it now. But I've seen it. Surgery also have consequences. It doesn't mean, no surgery is perfect, by the way. It's as any practitioner will use it as a last resort.
That's right.
If we could provide with the Botox a solution with mild bunions or mild
to moderate
Hallux abductor valgus.
Yes, right.
Is it, what's that? HAV. So then, as Abid said, it would actually enhance our practice, and our colleague, we can actually advise, teach our colleague in future that, hey, this is a safe, provided you follow the protocol, it is a safe option.
That's right. It can affect our, obviously we're trying to affect aesthetic outcomes, but we are also trying to affect function, mobility, so pain, discomfort. It can so that a patient can do the activities that they love to do, as well as affecting the aesthetic outcome. So let's go and get our patient, and this should be an interesting video. I'm not switching it on.
No, I know.
We're using sterile ultrasound gel
Yeah.
for this procedure. And let go. You okay?
Yes, fine. I can't feel anything.
Mm-hmm. Can you find the entry of needle? Is that your needle?
You okay?
Yeah, I'm fine. I can't
Okay.
feel anything.
Switch on the
Stimulator.
You
Yeah.
go up on the MA. Carry on. Is it going up?
Yeah.
Okay.
Yeah.
1 second. Carry on. Does it feel a bit strange?
No, I'm good. thanks.
Okay. Carry on.
Not 10.
Okay, leave it there.
Yeah.
I'm okay. I don't feel
Okay.
anything
Go
at the
up on the
moment.
MA. Leave it there. Put it back on the stimulator. Don't press the EMG. Thank you.
Yeah, it's tweaking.
There you go.
Yeah, can you
Okay.
record that tweaking?
Can you see that? Now that's
Feeling
the adductor hallucis. Now I'm just gonna aspirate, nothing coming out, and we're just gonna inject slowly. You can see the ultrasound there. You can see the muscle twitching rather, which is the
Yeah, you could. Shall I stop?
transverse head.
Shall I stop?
No, stop. Okay, go back of the toe. There you go, and we're all done.
I bet you're curious to find out how this patient got on in 6 months. Well, click on the link below this video to watch part 3. Let me let you into a secret. It was amazing. Absolutely amazing. So, see you in part 3.